Thank you, Rakesh. I thank the organizers for this opportunity. Well, as you all know, the understanding and management of Kawasaki disease has come a long way in last 2.5 decades or so, thanks to Professor Sujit Singh sir in North and his team, and Dr. Saji Philip, Professor Zulfikar Ahmed, Dr. Nageshwar Rao down south, and their teams, of course. So, and their subsequent generation is doing a great job to carry it forward. So, as the survival and outcome of Kawasaki disease in children is improving, it is but obvious that they will be having one or the other issues when they grow up. So, absolutely necessary in next few years and decades is the need of understanding of what they are going to present with when they grow up as adults. So hence this topic is perhaps of utmost relevance in the given Indian scenario. So scope of my talk will be under these headings. So what will be the usual adult presentation of childhood Kawasaki disease with respect to coronary involvement? Very, very brief literature review. How do we evaluate? Basic evaluation of adolescents and adults with history of childhood Kawasaki disease. Coronary angiography and intracoronary imaging, if we perform on these patients, what are we going to find and what is the indication and so on and so forth. How to assess in terms of functional status of coronary artery lesions and how do we manage them medically and what we can offer in our setup. And revascularization options for obstructive coronary artery lesions, what we can offer in our setup. So adults with history of childhood Kawasaki disease can come to us as grown-ups with no cardiac involvement during acute illness. They can just come for the information or as follow-up. With acute illness, history of acute illness with complete recovery also can present to us when they grow up. Cardiac involvement during acute illness with non-coronary sequelae in terms of systemic artery aneurysms or mitral regurgitations or other valvular regurgitation can be the presenting symptom to us. So the interest of topic given to me is cardiac involvement during acute illness with coronary artery lesions. What is their fate or what is their outcome and how we can offer them service when they grow up as adults. So you might have read this great study published long back in 1996, so which studied extensively about nearly 600 patients with long follow-up as long as 21 years of 600 patients. What did they do? They examined one every 3 years of all Kawasaki disease infants without coronary artery lesions. Small and medium-sized coronary aneurysms or regressed aneurysms were followed every 6 months. Giant aneurysms were followed every 3 months. So what did they find? The incidence of coronary aneurysms in acute were 25%. 55% of them showed regression, and ischemic heart disease developed in a nearly 5%, with MI in nearly 2% and death in just less than 1%. So this is what is important, isn't it? So what did they confer? So they questioned the need of long-term follow-up of children with normal coronary artery or long-term, and I believe, and many of the people believe that they need to be followed every 3 to 5 years, at least clinically. And patients with transient dilatation, they felt as there was no cardiac symptoms or ischemic findings in the long run, they thought the study is what I quoted, they thought there is need of long-term follow-up in terms of screening for coronary artery disease or premature atherosclerosis in the adulthood. So they also found when they did intravascular ultrasound later on, there is marked intimal thickening with or without calcification even in regressed coronary artery aneurysms. This is very important. Coronary artery wall was poorly distensible when they administered intracoronary nitrate. So vasodilatation was less pronounced compared to the normal coronaries. So it is understandable now that the sequelae of Kawasaki vasculitis may be present even in patients with regressed aneurysms, and atherosclerotic lesions might develop in early adulthood in such patients. So hence it is absolutely necessary, as you all aware, Indians or Southeast Asians are inherently at higher risk of developing atherosclerosis at much younger age, less than 15 years compared to the West. That is because of the genetic thing, SNP genes you might have read, involved with us. So it is absolutely necessary, because there will be a lot of overlapping if a 30 years old comes with atherosclerotic changes with history of fever in the infancy. So it is absolutely necessary for us to understand and avoid other atherosclerogenic risk factors, for that matter in normal people as well, especially in such patients, to avoid smoking, avoid getting obese, and screen and treat systemic hypertension, and of course the LDL levels, keep them in the normal range. So I searched a few case series reports and articles. The average says that the giant aneurysms are the things which needs to be considered if we need to follow them. So around 70% of myocardial infarction patients give history of giant coronary aneurysms when they grow up. That is the patients with history of Kawasaki disease in childhood. So around 50% of them develop stenotic lesions, making them to have symptoms of coronary ischemia. And none of them are likely to show any regression. So this is the subgroup which have to have a constant and regular follow-up. So what is the average presentation? As ma'am told, in their study it was 21 years, isn't it? The other study said it is almost similar. Around 25 years of age is the usual age of presentation with cardiac sequelae, either coronary ischemia or myocardial infarction or arrhythmia or diastolic or systolic heart failure. Ischemic symptoms predominate the symptomatology, around 60%, arrhythmias around 10%, and sudden cardiac deaths around 16%. As one of the attendee was asking, sudden cardiac death risk in the infancy. See, to have a sudden cardiac death, there has to be two things. One is pump failure because of complete occlusion of a major epicardial coronary artery, or an ischemic ventricular tachycardia, which can cause alteration in the perfusion of myocardium and other vital organs, leading on to the death. So either it has to be a complete occlusion because of the thrombus in the aneurysm, or it has to be an ischemic ventricular tachycardia which has caused sudden death. So what is the role of cardiology services? What is the role of adult physicians and cardiologists in such patients? We have to follow them even if they are not having any symptoms. We have to treat them with antiplatelets if there are persistent aneurysms, and statins depending on what is there in their lipid profile, and follow them closely, at least once in a year. And giant coronary artery aneurysms need to have anticoagulation and very close follow-up, even if they are not having any symptoms. And what if there is evidence of obstruction, either on non-invasive evaluation or by the clinical symptoms? So there can be a subgroup where there is obstructive coronary artery disease, but there is no ischemic symptoms on exertion. So that needs a medical follow-up along with antiplatelets and statins. So obstructive disease with atypical symptoms, some chest pain here and there, but not typical of ischemia, they need to be evaluated for objective evidence of inducible coronary ischemia. And typical ischemic symptoms on exertion, of course, needs to have the revascularization as and when it is required. And obstructive coronary artery disease with history of myocardial infarction may be the presentation of such patients in the adulthood. Then we have to understand whether the infarcted segment is viable or it is not viable to decide on need and mode of revascularization. So how do we evaluate? So clinical evaluation in terms of assessment of ischemic symptoms. Is there any obvious symptoms or ischemic equivalent like dyspnea on exertion, rather than typical angina on exertion? And we should always assess other ischemic heart disease risk factors, especially in our setup in terms of family history of premature atherosclerosis, either coronary involvement or cerebrovascular involvement. Examination in terms of body mass index for obesity, signs of premature atherosclerosis, resting ECG for baseline ischemia, is there any STT changes or Q changes at the baseline, to have a fair idea about their coronary status. Chest radiography, I was amazed to see the calcification of coronaries on the chest X-ray that we usually don't find when madam showed that. So chest radiography, presence of pulmonary venous hypertension is a fair idea of elevated LV and diastolic pressure, which may be secondary to the demand-supply mismatch of coronary ischemia. Resting echocardiography for regional valve abnormalities if it is resting coronary ischemia, and of course LV function needs to be assessed so that we can have better planning. And strain imaging is what is we are working with Dr. Rakesh and the radiology team to understand what is the strain imaging. Even if the resting echo, two-dimensional echo is normal, then we can assess with the strain imaging to assess the subclinical LV dysfunction so that we can correlate, so that we can manage better when they have symptoms. And fasting lipid profile, HbA1c, because we are at higher risk of developing all these abnormalities, high lipoprotein A levels, high homocysteine levels, high sensitivity CRPs. This is for the overlapping or ruling out non-Kawasaki premature atherosclerosis. So these needs to be evaluated for anybody presenting to us with ischemic symptoms with or without history of Kawasaki disease. So obstructive coronary artery disease, no ischemic symptoms on exertion, needs to be assessed for their coronary anatomy, LV function, and this compliance for antiplatelet statins. And we should do workup for inducible ischemia, even if they are not having symptoms on clinical evaluation. And if they have history of myocardial infarction, either by history or by ECG and echo findings, we need to assess their LV function and of course the viability to decide on further management. So once we do this basic evaluation, then we come to the proper assessment of coronary ischemia. I think we have a special session, or is it over, for the CT assessment. I am not going into the details. So this is an ideal thing for a screening tool for patients with Kawasaki disease now presenting in adulthood. What is the status of their CT coronary angiography? This is an excellent tool for screening. And assessment for inducible ischemia for patients who are having positive coronary angiography on CT in terms of calcium score and having plus minus symptoms. So this is an excellent tool to assess them for the need of revascularization. Exercise stress test, what we call TMT, treadmill test. Stress echocardiography with the injection of dobutamine. Thallium myocardial scintigraphy, thallium 201 radionuclide scan. Invasive assessment in terms of conventional angiography, what we do routinely for adults. Intravascular ultrasound, optical coherence tomography, fractional flow reserve, these are the functional assessment. Quantitative flow reserve assessment, quantitative computed angiography analysis, and CFR. So in exercise test, what we do, it's a simple thing. You attach a 12-lead ECG and there is graded increase in the patient's efforts in terms of metabolic equivalents. And you see for the changes in the heart rate, the blood pressure, and symptoms, whether he's having any angina or anginal equivalents. And you see for the objective changes in the ECG. As you can see, this is on exertion. You can see there is significant ST depression in 1-3 AVL, elevation in AVR, and V3 to V6, there is significant ST depression, isn't it? This is consistent with coronary ischemia when he is exerting on the treadmill. So suggesting that the coronary blood flow is not enough when he is exerting. So another non-invasive modality to assess is stress echocardiography. You assess the LV function, regional wall abnormalities, mitral regurgitation, and strain at rest, and you give dobutamine with sequential increase from 2.5 to 20 mics per kg. You assess for their new onset regional wall abnormalities, new onset or worsening of mitral regurgitation, and new onset LV dysfunction or regional wall ventricular dysfunction on stress. So this is positive stress test in terms of echocardiography stating that there is evidence of coronary ischemia. So thallium myocardial scintigraphy, as you can see, the resting and at exercise there is a lack of perfusion, isn't it? Again stating that this is the positive thallium. So coronary angiography is not routinely indicated in any adolescent presenting with history of childhood coronary artery disease unless he has evidence of coronary ischemia on clinical and non-invasive evaluation. So this is as per the Kawasaki Research Committee, how you divide the dilated lesions, because the management will be a little different in terms of revascularization if we attempt percutaneous one, and stenotic lesions, whether they are completely occluded, is there any segmental stenosis or localized stenosis. So everybody agrees these days just doing angiography is of lesser use and it is best combined with intracoronary imaging so that we can better understand the pathoanatomy and the management can be advised in a better way. So this is the intravascular ultrasound. As you can see, this is, you take reference of proximal and distal coronary artery diameter or area by intravascular ultrasound, and you compare with the dilated segment, you will understand that the aneurysm diameter and area will be much higher. So not only that, you can understand the calcification state and microvessels, as you can see here. Microvessels development indicate that there are microthrombi and fibrosis in the intima as well as media, which is at higher risk of a risk of having a coronary event in the near future. So we can assess the aneurysms, we can assess the stenosis. As you can see, the usual site of stenosis is the junction between the aneurysm and the normal segment. That is the usual site of obstruction or stenosis in Kawasaki disease. Whereas in atherosclerosis, the lesions will be more diffuse rather than localized. And this is from our own lab. As you can see, this is dilated, isn't it? This is how you see in the intravascular ultrasound. And this is what is known as negative remodeling. You can see this is bigger, this is smaller, right? So that is because of the fibrosis or the negative remodeling, what we call. And this is the calcium. This is the hyperechoic lesion, is the calcific nodule, not this white one, the black one. So stating that the hyperechoic lesion is calcific nodule in the left main coronary artery. This is fibrotic plaque. You can see it's a relatively longer segment lesion. So the advantage of IVUS is it does not require any contrast, but the disadvantage is it is invasive and it needs some training to understand and interpret these images. We have another modality. All these are available with us in our lab. So that's why I'm stating that what we can offer to the patients when they visit us. So OCT is optical tomography, where you can see it's a post-tented status. As you can see, this is the long vessel view, what they call. So this is more dilated, isn't it? So that is the aneurysm. Though you can assess what is the length of aneurysm, what is the diameter of aneurysm, so that we can decide on the stent. So stent appropriate apposition to the wall will prevent the risk of thrombus in between the stent struts and the vessel wall. You understand? So, and this is the calcification. As you can see, this is the calcific nodule. This is protruding, not this one, the behind one. And these are the superficial calcium, the less colorful things. And this is more deeper calcium. These are best appreciated with the help of OCT. This is what we routinely do for adults having coronary artery disease because of atherosclerosis. The advantage of this OCT is it is very easy to understand. You can see the colorful pictures and you can understand and interpret, but it requires contrast, which may be a little tricky because every injection requires some 20 ml of contrast. So it is a little tricky and it is of course invasive. And functional assessment, if we are not sure based on the anatomy and clinical symptoms, we can do what is known as functional assessment of coronary artery lesions. This is QCA, quantitative coronary analysis. This is all software computer driven thing. You just put a point here, and we can get what is the percentage of narrowing, what is the percentage of luminal area at that site, and what is the plaque burden and what is the status of the lesion there. And quantitative flow reserve is the combined FFR and QCA, where we can easily identify whether the lesion is significant enough to cause coronary ischemia. Is it significant enough to make the patient to have coronary complication in terms of myocardial infarction or sudden death, so that we can decide on intervening that lesion. FFR is probably the most specific thing. You measure the pressure before the lesion and after the lesion with the help of this pressure wire. And the ratio of that obviously give the severity of this lesion. You do at rest and you make the coronary hyperemia by giving intracoronary adenosine or NTG, and you assess less than 0.8 is considered as significant, stating that this lesion is quite significant for this patient. So apart from assessment of coronaries, it is important for us to know that there is very common is premature atherosclerosis in our setup, especially in 30s. As we know that the incidence of coronary artery disease in India is rising, and 1/4 of 25% of patients having myocardial infarction in India are aging less than 40 years. So less than 30 years, MI is contributing to 15% of myocardial infarction and death in India. So if somebody of age 28 comes with myocardial infarction, not necessarily it is premature atherosclerosis alone. In the same way, it is not necessarily to be because of the childhood Kawasaki disease. So we need to understand and try to differentiate, because the management will be a little different in terms of family screening and prevention of similar things in the family if it is atherosclerotic lesion rather than the Kawasaki disease related. Kawasaki will not be familial, right? So as I have mentioned here, the age group, history, family history, associated other coronary artery disease risk factors, involvement of coronary, either it's ostial or proximal, presence of calcification, all will help to differentiate Kawasaki disease with premature atherosclerosis. The important is, as ma'am also agreed, PCI, as per the available literature, PCI is not the best as far as Kawasaki disease is concerned, whereas it is proven beyond doubt in thousands of studies that PCI, that is percutaneous coronary intervention, angioplasty and stenting, is not inferior to CABG in selected cases. So there comes a difference in the management. So challenges for percutaneous intervention in Kawasaki disease is presence of very high calcium. Almost always there will be calcific. So to modify that plaque which is having high calcium before putting a stent is very, very tricky, because the stent has to expand properly so that we can minimize the risk of stent thrombosis as well as stent restenosis. And complications will be much higher if the calcium is higher. Instant restenosis rates are higher if the calcium is quite high. And aneurysm will put challenge on us to decide on selection of the stent, and the risk of stent thrombosis is higher because the slow flow rate after stenting is higher. If aneurysm mein flow kam ho jata na, when the diameter is more, the flow will be lesser. So that will be a challenge to manage in the post stenting status. And multiple segments, if they are involved, selection of stent and stent restenosis will be challenging. And bifurcation lesion, when it is at the very origin, and bifurcation, size discrepancy, if at all it is there, it has got some technical issues, but it can be tackled. And for challenges, bypass graft ke liye, I think again calcium and aneurysm are a little tricky. And for surgeon it is little easier because it's almost always proximal vessels are involved, and they put a graft always in the mid segment or much beyond the mid segment. So for them it is okay. That's what I am not aware of graft failure rates in Kawasaki disease compared to atherosclerotic disease with graft long-term outcome. And experience of surgeons is little lacking in our setup. Maybe next few years it should be okay. So what techniques we have in our setup, in our own lab in PGI to tackle this high calcium? We have cutting balloon devices, the wires at the edge of the balloon, we can tackle that calcium. We have rotablators, a diamond tipped burr where we can drill the calcium. We have orbital atherectomy where it rotates in both directions so that the calcium can be taken care of so that the stent can be placed easily. We have shock wave, similar to what we use for calculus anywhere else. We have in the coronary calcium ke liye bhi. So the balloon and the shock wave will reduce the calcium load so that the stent can be implanted easily. So in my opinion, the challenges in Indian scenario are quite high. We need to have further improvement in knowledge, attitude and practice in terms of Kawasaki disease in the periphery of our country. And we should be aware of the sequelae in adulthood. All physicians should be aware of it. We tried our best when we started our program to give exposure to the basics of coronary artery disease for pediatric cardiology trainees and the basics of coronary artery disease management when they face such patients in their future. And adult cardiologists, our trainees are given the best possible knowledge of Kawasaki disease and its long-term cardiovascular sequelae, but they are not that interested, as you can see from the attendance from my department. Dedicated team is the need of the hour. The pediatricians, the radiologists, the cardiologists, surgeon, and adolescent medicine is perhaps a newer subgroup. We need to form a dedicated team to tackle such patients when they visit to us. And we need to form consensus or guidelines for the management of symptomatic and for the management of asymptomatic obstructive coronary artery disease in grown-ups with history of childhood Kawasaki disease. We need to have our own consensus and guidelines so that we can manage them better when they fail. This is what I have shared with my friends. I propose this protocol. I'll share with you all. We can think on this, modify this, and make up with a plan when we need to face patients with history of coronary artery disease in their childhood. So with this, my take-home message will be very simple. Kawasaki disease, originally a disease of infants and young children, is going to be perhaps very high on the lists of acquired heart disease in children and young adults in the near future. Coronary artery disease, sequelae of Kawasaki disease, will be an important cause of ischemic heart disease in young adults in the near future. One should always elicit the history of childhood Kawasaki disease in younger patients with ischemic heart disease. This is for the physicians. And Kawasaki vasculitis can independently develop into premature atherosclerosis in adulthood. We need to be aware of this. And percutaneous and surgical revascularization is challenging, but it is definitely feasible. And dedicated team and center will be an absolute need in the next decade to manage such patients. Thank you very much.
Thank you, sir, for such a lucid talk. So we have taken us through that, what we can do and what we have to do. Earlier, there are a lot of challenges, but we have faced these challenges earlier in the better. So we have seen that in coming years, we have to see many patients with those who will be presenting with a myocardial ischemia or acute coronary syndromes because of Kawasaki disease. So both talks are being open for such talk is also open for comments or suggestions.
So just to have the basic idea about this, what we can expect in the future, what study you are doing, I'm trying to look for the subtle ventricular dysfunction, subtle wall motion abnormalities by tissue Doppler and strain imaging. We have found a couple. Once we correlate with them with the MRI and other echo and other things, we can come up with a little bit of better information in asymptomatic patients.
Yeah, very interesting. Interesting, I won't use the word, very scary and challenging problem we are going to face in the future. So, since I'm in a teaching hospital and planning to give a thesis, or we can do a research multicentric trial where we can follow, we can, have a combined study with the cardiologist. So all those MIs, because in Heart Center we are getting 25, 27 years with diffuse coronary disease needing bypass. Stents have no role there. So we are getting lots of such patients, but we do not know now. Retrospectively, I think maybe it is because of underlying coronary. So maybe combined study with cardiologists and pediatricians, all those adults less than 50 years having MI, and all those children with KD. We can have a study for a long time. So maybe a multi-centric trial. We also get lots and lots of patients in EMC, and PJ of course is the number one in the country. Thank you so much.
Ma'am, regarding diffuse atherosclerosis or diffuse lesions, so we need to be doubly sure whether it is premature atherosclerosis versus such Kawasaki disease sequelae.
What test would help? Calcification? How will you
So, no ma'am, calcification we have seen at the age of 19 also. We have to correlate everything, right from family history to LDL receptor status to their genetics, to their smoking, to their body mass index, to their lipoprotein levels, their homocysteine levels, and their coronary status in terms of angiographic findings, presence of calcium, and what segments are involved. Is there any aneurysm associated with stenosis? And everything taken into consideration, then we can have a better understanding. And of course, the coronary imaging, whether the calcium is localized or calcium is diffuse, whether it is node.
go in favor of aneurysm?
No, localized always indicates the inflammation was at that point, right? That goes in favor of Kawasaki, because the involvement of coronary is segmental, is localized, no, rather than whole of coronary.
That's a good idea, because cardiologists' eyes will see what the mind knows. They are not even aware of AD. So they may not be looking from that point of view. That's why they just label diffuse. But it could be underlying aneurysm. So that's a good way to.
Yes, yes. The other thing is at least at this point of time, there is no major difference in the management of coronary artery lesions once the infarction has already occurred. Once the part is dead, that LAD territory is dead, then the treatment will be for the other vessels and conservative management. If it is ischemia proven, then the treatment is easier, either percutaneous or the surgical revascularization. The question comes with borderline stenosis, with dilatation of 2 times or Z-score of just +2, +3, with or without symptoms, question comes there. Because it's obvious is obvious. So we need to catch them before it is obvious.
Sir, for this, the vitamin stress test, is there any particular age cutoff after which we can do it? And if there is an age cutoff, then is it related to vitamin-related arrhythmias or something else also in side effects?
So if there is already manifest ventricular dysfunction, then it is not going to help you much, isn't it? So dobutamine, by the virtue of increasing myocardial contractility, heart rate, making the heart to have more demand, will help us whether there is any ischemia when the heart is under stress. And there is no cutoff. We can do at 10 years also, we can do at 12 years also, adults also we routinely do. There is no cutoff as such. And yes, there is always a risk of, we always take consent of arrhythmias and developing MI even during treadmill, because they are at risk. They may develop MI when they are running on treadmill. Even dobutamine injection, they can have coronary ischemia.
And sir, the obstructive lesions with the underlying infarction, so beta blockers versus ACE inhibitors, which of these are the preferred one and which will prevent the cardiac remodeling better in between?
Cardiac remodeling is always ACE inhibitor. Beta blocker is going to have effect by reducing the myocardial demand, by increasing the diastolic filling period, reducing the heart rate, diastolic time will be more, diastolic filling will be more, coronary perfusion is during diastole, the perfusion will be better, LVDP will be better if the heart rate is controlled in terms of that. Both needs to be given, but isolated if you say cardiac remodeling ke liye A is better or B, ACE inhibitors are proven to be better.
Thank you, sir.
Thanks.
If there are any more questions, we can take a quick break for the then create some learning guidance.
Thank you.